Good afternoon. My name is Craig Hooper. I'm Division Director of Blood Disorders at CDC, and I really would like to thank everybody for joining us today. You know, I realize that many of you guys have serious time constraints, so hopefully we can finish sooner than later. You know, our division has been aware of issues in sickle cell and reproductive health. Can you go to the next slide? I can't.
Yep, there we go.
That's not on my side.
Okay, hold on. So sorry.
Anyway, while Carrie's doing that, we've been aware of issues in sickle cell and reproductive health for the past 10, 11 years. You know, and about 10 years ago, we found some data that suggested that women on OC use that had sickle cell trait had a higher rate of thrombosis than those without trait or that are with only disease only. And so that told us, that trait should really be thought about in terms of OC use. That is when I first realized that no one really cared. You know, there was no interest in sickle cell trait and thrombosis. And our numbers were so small, we really could not make a strong case. 3 or 4 years later, Sherry Boulay, who is now at Emory, she looked at administrative data, and she found that women with sickle cell disease had a higher rate of complications as compared to women with other risk factors for multi-organ failure, such as lupus. Again, this highlighted what was going on with that population, and it highlighted what was not being done for that population. You know, others have had similar findings. Others of you have had frustrations with that. Nobody really cares what's going on in this population. And some of you may disagree, but it really appears to me that while there is great subject matter expertise out there, it may be somewhat siloed. People don't know who each other are. There's really no ways to work with one another. How can people work together as a group? What can everyone do to get data that can bring action? And so the objectives of this workshop are, on the slide, I don't know if you can see it or not, is to increase collaboration. How do we increase data sharing? And more importantly, how can we use this data to bring action? That is the most important thing. And you all have heard and you all have said data for action. And this is when we really need data for action. The way this workshop is going to be, it's not your traditional webinar because this is not the way it's intended. We have some speakers and we have discussants. The discussants are panelists. They know who they are, and only them, our clinicians, should talk. This is for clinicians to talk among themselves and how can we bring change. What are the issues? So the structure of this webinar or online chat or whatever is Andy James, Kim Whitley-Smith, and Michael Patus, if he's on the line. They're going to set the stage. Lydia Pecker from Johns Hopkins, she is going to frame the issues. Then we're going to have like a 5-minute break so people can think about what they heard. And then when we come back, Mary Houlihan is going to talk about how can CDC sickle cell data collection, how can that help address some of the questions that Lydia has framed. Sherry Boulay, hopefully, who can join us, will talk about how valuable it is to collect data the correct way. You know, data is only useful if you collect it, that it can be used and analyzed, that can make an impact. And finally, Kim Whitley-Smith, she'll lead a discussion on the issues that Lydia had framed and get the input from all the discussants and clinicians. And then to wind the day up, Kim will talk about next steps. her, Lydia, and Andy, they've got some really good ideas on what the next steps are. I believe that everybody realizes, talk is cheap. It's the next steps is what has to be done. And this is really critically important in this area. There has to be next steps. But the first step is to get you guys together, talk together, and then go from there. So with that, Andy, Kim's going to set the stage, and hopefully Michael can chime in if he's on the line. Thank you.
Okay, Carrie, do you have my slides? Okay. Can everyone hear me? Carrie,
Yeah.
Kim, Greg? Okay, good. I'm Andrew James. My nickname's Andy. I'm an obstetrician gynecologist. I'm a specialist in maternal fetal medicine. I have a joint appointment in the Division of Hematology at Duke University. I provide obstetrical care to sickle cell disease patients at Duke, and I serve as the liaison between our sickle cell disease clinic and women's health at Duke. I'm passionate about the care of women and girls with blood disorders, and I know many of you through the Foundation for Women and Girls with Blood Disorders. Next slide. In general, as we frame the issues, they are condensed. Sickle cell disease impacts women's reproductive health, and pregnancy, menstruation, and contraception impact the disease. Next slide. So I've been taking care of women with sickle cell disease since 1975, when I was a nurse midwifery student at Johns Hopkins. At that time, the life expectancy of a young woman with sickle cell disease, or a person with sickle cell disease, was 12 years of age. Life expectancy has changed dramatically since then. When we saw women with sickle cell disease in our maternity clinic in the mid-70s, we told them they should not plan to continue their pregnancies because it put them at such risk, and their baby was not likely to survive anyway. That has changed dramatically in my lifetime with the remarkable improvements in the health of patients with sickle cell disease and life expectancy. We've got a ways to go. There are still issues now related to reproduction. Next slide. So they cluster around menstruation and contraception, fertility preservation, preconception considerations, pregnancy management, and now perimenopausal management. I have 4 cases that illustrate the issues with menstruation and contraception, fertility preservation, preconception, and pregnancy management, and I hope they serve as a springboard for further discussion. Next slide. So the first scenario is a 16-year-old with heavy, painful periods. She has sickle cell disease. She had menarche at age 15. The onset of menses triggers vaso-occlusive crises, and she's able to distinguish menstrual pain from her vaso-occlusive pain. Fortunately, she has no personal history of stroke or venous thromboembolism. Next slide. You may already have noted that she had relatively late menarche, but age 15 is the median age of menarche for a patient with SS genotype. AA genotype, the median age, the mean age of menarche is 12 or 12 to 13. A little later with SC, and with SS genotype, clearly a delayed menarche relative to unaffected peers. These are data from Jamaica. Next slide. So in terms of managing her heavy or painful menstruation, in OBGYN, we rely on hormonal therapy. There are no specific data on management of heavy menstrual bleeding or dysmenorrhea in girls with sickle cell disease. We do know that hormonal therapy can reduce blood loss and pain with periods in general, and that's positive, but combined hormonal contraceptives, meaning hormonal contraceptive with estrogen and a progestin, increase the risk of venous thromboembolism and stroke, a negative, and Depo-Provera injections or depo-medroxyprogesterone acetate injections increase the risk of venous thromboembolism by about twofold, but other progestin-only contraceptives do not. Next slide. Nsaids, which are nonsteroidal anti-inflammatory drugs, which are another mainstay of our management of dysmenorrhea, may increase vascular bleeding and renal risks. Risks may be compounded in patients with end organ comorbidities. Long-term safety data are lacking in sickle cell disease, but without a contraindication, they are generally considered acceptable. Next slide. Now, I hope that's given you something to think about in the young woman who has heavy menstrual bleeding and dysmenorrhea. The next case here is a 19-year-old young woman who's undergoing stem cell transplant. She's SS genotype. She's had multiple episodes of acute chest syndrome and vaso-occlusive pain crises. Her sister was an HLA match. She was referred to reproductive endocrinology and infertility. She was counseled about the options of cryopreservation of embryos created with donor sperm. And the advantage of that is it allows for pre-implantation genetic testing for sickle cell disease. She was counseled regarding the options of cryopreservation of oocytes or eggs, and she was counseled regarding the options of cryopreservation of ovarian tissue. It's experimental, but the only option for prepubescent girls. Next slide. So a low-dose stimulation protocol was used. Peri-procedure enoxaparin prophylaxis was used because of the prothrombotic effect of the ovarian stimulation process. 8 mature oocytes were vitrified, i.e. rapidly cooled. A successful pregnancy has not been reported in this case, but thousands of pregnancies have been reported after oocyte cryopreservation. No reason to think it wouldn't work. 87 after ovarian tissue preservation and 2 in sickle cell disease. Next slide. So the next patient is somebody who's coming to see me. Well, we've had to move her appointment because of our COVID concerns, but she has SS disease. She's been on hydroxyurea for 8 years. She has a history of venous thromboembolism related to a central line. She has a history of delayed hemolytic transfusion reaction attributed to anti-S antibodies. The titer is 1. She has a ferritin of 44. Next slide. So what do we consider in counseling a patient who comes in for preconception consultation, whether they have iron overload or not? Our American College of Obstetricians and Gynecologists, without real data, recommends 4 milligrams a day of folic acid. Screening for hypertension, this patient does not. Sickle cell nephropathy, this patient does not. Proliferative sickle retinopathy, this patient has been to an ophthalmologist and does not have retinopathy. She has had a recent echo. She doesn't have any evidence of pulmonary hypertension. She's assumed to have functional asplenia. Her vaccinations are up to date. She is alloimmunized, and we gave her partner the option of being tested for S antigen, and I'll come back to that later. Patients who are on ACE inhibitors for renal protection, we discontinue prior to conception. It's teratogenic or teratogenic. And if the partner's status is unknown, we refer for testing. If the partner has abnormal hemoglobin, we refer for genetic counseling. And if the couple are at risk of having a potentially affected child, we offer pre-implantation genetic testing with IVF. So this young woman, she succeeded in becoming pregnant after she saw me for preconception consultation. She miscarried. She conceived spontaneously again. She miscarried, and rather than, and it turns out her partner does have S trait, and rather than go through IVF and pre-implantation genetic testing, she opted to conceive with a donor egg, and she is now 10 weeks pregnant. Next patient. Next slide. So this is our most recent patient. She was just discharged this weekend. She's 23-year-old gravida 1 at 32 weeks. She was followed by our sickle cell clinic, who have a presence at a large outside community hospital about 100 miles from Duke. And she saw me periodically during the pregnancy for co-management of her prenatal care with the anticipation she would deliver at Duke. But on the 31st, she presented to an outside hospital after being transferred there from a small community hospital emergency department. That hospital doesn't do obstetrics, and the patient had upper and lower extremity pain, which she described as typical of her sickle cell crises. She received labetalol, morphine, and Zofran there, and then was transferred to the larger community hospital. Prior to her pregnancy, her most recent crisis was in March of last year, and that was the only time she was ever transfused. She reports too many hospitalizations, however, to count, and she's had acute chest syndrome at least 3 times. This pregnancy, she was hospitalized for a vaso-occlusive crisis at 23 weeks and for right upper quadrant pain at 26 weeks, which remained unexplained and resolved spontaneously, and she had a normally grown fetus. Next slide. She has sickle beta thal. In the past, she's had tonsillectomy and PE tubes. Her medications when she was admitted to the outside hospital were prenatal vitamins, folic acid, low-dose aspirin, oxycodone, and she had been in the hospital for a triage visit to rule out preterm labor in the previous 2 weeks and had received steroids for fetal lung maturation. No allergies, family history significant only for a mother with rheumatoid arthritis and sickle cell trait in her family. She lives with her mother and she doesn't use any substances, and the father of the baby is involved and was tested for sickle trait and screened for thalassemia, and he was normal. Next slide. At the outside hospital, she was 5'1" and 200 pounds, which gives her a BMI of 90, so she was obese. Her blood pressure was, that should be 149/116, quite elevated. Her temperature was 100.1, her heart rate was 106 17, her O2 sat was 95%. Her exam was benign. Her labs, she was tested for flu, and that was negative. Her hemoglobin was 8.2 in admission. Her hematocrit was 24%. Her platelets were 109, which was down from about 200 during pregnancy. Her creatinine was 0.8. She had had an LDH of 765 and a ferritin of 806 5 days earlier when she was seen in triage there. So the admitting physician at the outside hospital diagnosed her with severe preeclampsia and a low-grade fever. She underwent induction of labor with Pitocin. She was given magnesium sulfate for seizure prophylaxis, but she was, for reasons that are not clear, either she or her local obstetrician decided not to transfer her to Duke, where her sickle cell providers are. Next slide. So during labor, her urine output dropped off. Her creatinine began to rise. Her magnesium was discontinued as she became increasingly drowsy. She developed late decelerations and underwent a cesarean delivery. The baby was healthy and was admitted to their newborn intensive care unit, where the baby remains on CPAP. The next morning, however, the patient developed a fever with a temperature to 103. Her LFTs increased, her creatinine rose to 1.3, her hemoglobin was 4.2, her platelets dropped to 63, her LDH was up to 1100. So her obstetrician thought that it was most likely hemolysis, and because she might have TTP, he asked for a transfer to Duke, and she was life flighted to Duke and admitted to the obstetrical service with hematology consulting. Next slide. Next slide. So what are the issues we have to deal with in pregnancy? In a normal pregnancy, blood volume increases by 50%. Plasma volume accounts for most of that, red cell volume less, but that's hard to achieve in a patient with sickle cell disease who is already making red cells as fast as she can. Next slide. During pregnancy, the immune system is altered to accommodate a fetus whose genetic makeup is half paternal. Women with sickle cell disease are already more vulnerable to certain infections, and that's compounded in pregnancy. Next slide. During pregnancy puts strain on renal function. There's an increased demand on the kidneys. In normal pregnancy, glomerular filtration increases by 50% or more, and that may be hard to achieve if there's any underlying renal disease. Next slide. Also during pregnancy, cardiac output increases by 40 to 50%. And in a woman who has underlying cardiovascular disease or any element of pulmonary hypertension, that may put her life at risk. Next slide. And pregnancy increases the risk of thrombosis. These are data from a Scandinavian database. Along the x-axis are weeks gestation, and the y-axis are number of events. And you can see that the risk of thrombosis in pregnancy increases in the first trimester and remains elevated during pregnancy, and then it's remarkably elevated by 20 to 80-fold postpartum. And this is superimposed in a woman with sickle cell disease on an already hypercoagulable state. Next slide. So not surprisingly, there's an increased rate of maternal complications during pregnancy and delivery. Next slide. Back in 2008, we published data using the nationwide inpatient sample, and we found an increased risk of thromboembolic events, the statistically significant for deep vein thrombosis and cerebral vein thrombosis. Next slide. We found increased risk of maternal infectious complications of 2 to 12-fold. Next slide. These are data from systematic review and meta-analysis that was published in Blood in 2015. And on the, these are data from low-income countries and high-income countries. And it doesn't matter what the background risk of preeclampsia is or where you are. Sickle cell disease increases the risk of preeclampsia 2 to 3-fold. Next slide. The next slide, please. And increases maternal mortality approximately 6-fold. Next slide. And not surprisingly, there are fetal and neonatal complications. Next slide. We know that sickle cell disease results in acute and chronic organ damage. One of the organs that is impacted is the placenta. So resulting in increased risk of adverse fetal outcome. Next slide. Preterm delivery is increased 2-fold. Not completely clear whether that's due to spontaneous preterm labor or whether it's due more to intentional preterm delivery because of growth restriction or preeclampsia, but we'll try to look at that. Next slide. An increased risk of small for gestational age infants by 3-fold. Next slide. And an increased risk of stillbirth increased by 4-fold. Next slide. So in counseling the pregnant woman or taking her through pregnancy, we talk about hydroxyurea. This patient was not on hydroxyurea. The patient who was we saw for preconception consultation was. We may want to discontinue it if it's not already discontinued, and we may need to restart it in exceptional circumstances, and we could make a whole day of meetings out of the pros and cons of doing those things. We do discontinue chelation agents. We recommend low-dose aspirin starting in the starting after the first trimester because of the high risk of preeclampsia. There's the risk of severe anemia. We recommend monthly complete blood counts because of the risk of placentally mediated adverse pregnancy outcome. We recommend serial ultrasounds for growth and fetal surveillance. Half of women with sickle cell disease will wind up with a cesarean delivery. So ideally, we'd have the hemoglobin close to 8 as we approach delivery. Pregnancy increases the risk of stroke by 3-fold. Consider an individual plan for thromboprophylaxis. We talked about the high risk for VTE because of underlying hypercoagulability of a patient with sickle cell disease and the superimposed 4 to 5-fold increased risk during pregnancy and 20 to 80-fold increased risk postpartum of thromboembolic events. And then we have patients who are on chronic opioids. And so our nursery needs to anticipate that withdrawal will occur, as is true in 6% of neonates exposed to opioids. Quite frankly, our newborn intensive care unit isn't impressed, however, with the doses our sickle cell patients take compared to the patients who are abusing opioids. Next slide. So back to our 23-year-old Gravida 1 at 32 weeks. After she got to Duke, she had a low-grade temperature. Her heart rate was in the 120s. Her O2 sat was 80s off of O2. She had an otherwise benign post-op exam. Her labs were very similar to what they were when she left the outside hospital, and I mentioned earlier. On a blood film, she had no schistocytes. Chest x-ray, she had a right lower lobe pneumonia. CTPA, there was no evidence of pulmonary embolism. The impression was acute chest syndrome, and she was started on antibiotics, but she came from a community with community spread of COVID-19, and she met our criteria for evaluating her for COVID-19, so she was tested for COVID-19, and then she was considered a patient under investigation, which created a lot of consternation with her family, who likened us to treating her with the plague. As far as her HELLP syndrome and her anemia, which, yes, she had a cesarean delivery, but true, she was also hemolyzing. She was transfused 3 units of red cells. She had an ADAM TS13 assay, which came back negative. Next slide. She improved clinically in her hemoglobin and hematocrit. Her platelets or LFT subsequently improved and stabilized. And on hospital day 4, she was discharged with a platelet count of 97, a hemoglobin of 7.3, a crit of 21.5, a creatinine back down to 0.6, and normalizing liver function tests. She was sent home with levofloxacin for her pneumonia/acute chest syndrome and enoxaparin thromboprophylaxis. She's due to see me next week. Next slide. So I hope that these cases help personalize the issues that we have to deal with in our patients with sickle cell disease. We have reproductive healthcare providers, particularly in OBGYN, who do not appreciate the pathophysiology of sickle cell disease. We have to help them understand it's not just pain and anemia. We don't have enough sickle cell disease providers, let alone enough reproductive healthcare providers who understand sickle cell disease. And the centers with the requisite combined expertise are few and far between, particularly in this pandemic where people are told to stay home. 100 miles, which is always a long distance, becomes an exceptionally long distance. And they don't want to leave their communities to have their babies and get care elsewhere. Next slide. So in summary, women with sickle cell disease are living into and through their reproductive years. They should be aware of their reproductive options. They're still at high risk of complications and clearly can benefit from multidisciplinary care and a system that supports that. Next slide. These are my supportive colleagues in the sickle cell clinic: Dr. J.J. Strauss, Regina Crawford, Nirmish Shah, and Sohir Adam. Next slide. And I'd like to greet all of you from Duke, where we bleed blue. Thank you.
Hi, it's Kim Smith-Whitley. Andy, thank you for that wonderful introduction to this topic. I am going to hopefully further add to the discussion this morning by pointing out some of the women's issues in sickle cell disease that demonstrate the health disparities in the past and the present, and the need for advocacy in the future. I'm the director of the Comprehensive Sickle Cell Center here at the Children's Hospital of Philadelphia, where I'm privileged to take care of almost 1,000 individuals living with sickle cell disease. About 52% of our population are women and girls. One of the frustrations over the years has been the inability to provide information on what they can do to preserve and improve their reproductive health, and what I can do as a physician to make sure that they get that excellent care. And I think that one of the things that I hope just my discussion today will be to ask, where is the interest for this patient population? What other organizations have been working to try to fill in some of the research gaps? Where are the data, if there are any data? And then where are the resources that we need to really address the clinical care in this population and the education for the patients and the providers? Next slide. We know through just listening to Andy's talk this morning that the issue for maternal outcomes of pregnancy are complicated in women with sickle cell disease. We know that historically, maternal mortality rates have been extremely high, and that has classified individuals who are pregnant individuals with sickle cell disease who are pregnant to be considered high-risk pregnancies. However, as we gathered data in the early 1970s from the Cooperative Study for Sickle Cell Disease, and we realized that it was possible for women with sickle cell disease to have good outcomes of pregnancy, we were not good at communicating that information to the community. So I tell the story often that as a fellow, as I was transitioning a young adult with sickle cell disease to an adult care program, that young adult, that woman looked at me and talked about the fact of how great it was that she had grown up in a sickle cell program and was graduating the program to go on to nursing school, and that her sadness was that she would never be able to have a child to come back and to benefit from the care that she had received at Children's Hospital. And in talking to her about this, I realized that she had no idea that she could be fertile and that she actually could have children and have healthy children and survive that. So our inability to really educate women with sickle cell disease about their reproductive health was happening even in a poor way in comprehensive sickle cell centers. We also know that there were things that came out on hormonal contraceptive agents in the 70s that implied that women with sickle cell disease may be at increased risk for thrombotic complications. We know that the packaging on some of these hormonal contraceptive agents actually cautioned not to use these in women with sickle cell disease with very little data. So this further increased the disparities for young women who were seeking contraception, as well as limiting our abilities as providers to understand what the best contraceptive agents may be for those living with sickle cell disease. Further, this was complicated by some of the social, psychosocial studies that were being published at the time on whether or not young women who were at risk for having children with sickle cell disease would make a choice to do something different with their pregnancy if they knew that they were going to have a child with sickle cell disease. And because of the results of that study, many people use those studies to support not doing good genetic counseling for women with sickle cell disease, not being able to talk to women with sickle cell disease about their risk for having a child with sickle cell disease, as well as those with sickle cell trait. So that really this further worsened disparities by not addressing these issues head on. For fertility preservation, we know that many curative therapies and disease-modifying therapies hopefully will be forthcoming in the sickle cell community. What we know about fertility preservation for outcomes for curative therapies is in a backdrop of not understanding what fertility is in the population in general. So we really do not have great information on fertility across the lifespan in women with sickle cell disease. And so we don't have a good comparator when we're discussing curative therapies. And then, of course, we know the issues with disease-modifying therapies such as hydroxyurea, and the message that has been unfortunately communicated to the sickle cell community is that hydroxyurea could have a negative outcome on pregnancy. And unfortunately, we have not done anything in the medical community for women to really better understand whether or not that's an issue. And I'm hoping that Dr. Pecker will address that in her presentation. But we need to gather this information so that we can counsel women living with sickle cell disease about fertility, how best to preserve it if it is at jeopardy across the lifespan. And then finally, where are the disparities and the need for advocacy in screening for sickle cell trait and sickle cell disease? I think most of you are aware that newborn screening for sickle cell disease started in the 70s and then was more globally adopted by the states in 1992. But what you may not be aware of is that trait information was often not stored. And so that individuals with sickle cell disease may not be aware of their, sickle cell trait may not be aware of their trait status across the lifespan. So just at the time where you have a young woman who is transitioning from a pediatric to an adult focused program in the general population, they need to know their sickle cell status, they need to know their hemoglobinopathy trait status, and they need to understand whether or not they're at risk for having a child with sickle cell disease. And that data that may have been present in the newborn period may not be accessible to them. So who is screening? Why are they screening? When are they screening? How are they screening? What tests are they using? Another disparities issue, and what happens to the results. So how they are screening in many institutions that screen for sickle cell disease in different clinical states, they're using a test that really shouldn't be used for genetic counseling, and that's called the Sickle Dex. That really is a poor way of identifying those with trait, and unfortunately, counseling based on that test may be very, genetic counseling based on that test may be very misleading. So we really need to take a step back, understand where we are with these issues and where we would like to go. So where is the interest in the community? Where are the data? And where are the resources? Next slide. So is there low-hanging fruit? Are there things that are out there in the community that are being done for other chronic illness populations that could be adopted for the sickle cell community to address some of these data gaps and research gaps? We do not have a registry and surveillance system that is national, that is accessible to all. And we really need to understand what's happening to women with sickle cell disease, particularly during pregnancy, so we can get good maternal outcomes data, and also across the lifespan as they go into menopause and what's happening with bone health. And really, registry and surveillance may help us with some of those outcomes. Also, we know that there are other chronic illness or rare diseases that have really linked into other resources that are hot topics nationally, and cystic fibrosis has demonstrated that as they have really linked into AAP's Got Transition. And is there an opportunity there for the sickle cell community to link into another network to be able to provide tracking and resources for reproductive health education through other entities like the American Academy of Pediatrics? And then where are the education resources, not only for the providers, but for the patients as well, as we need to at least spread the word about what we know is the right thing to do now, as we also better address the research gaps and what we need to improve on. Next slide. I think that many of you all are already aware of this very short list of what some of the opportunities could be for research or for quality improvement initiatives. We know that a systematic approach to pregnancy with a multidisciplinary team improves outcomes. We know that reproductive health plans for women and girls not with chronic illness are recommended through federal agencies, but where is that opportunity for women and girls with sickle cell disease? We know that there are recommendations for the use of aspirin and VT prophylaxis in pregnancy at various stages, but is there an opportunity to gather information in a registry and surveillance system in order to better develop guidelines? Russell Ware and the Foundation for Women and Girls with Blood Disorders has really addressed hydroxyurea and why we need to get more information on hydroxyurea in pregnancy and breastfeeding women so that we can give better advice about whether or not it's safe to use hydroxyurea in late pregnancy and while breastfeeding. Of course, the need to get more information on opioid exposure during pregnancy and neonatal abstinence, as well as in women with sickle cell disease who often have red cell antibodies and have babies who are at risk for hemolytic disease of the newborn. How can we address that with the infrastructure that we currently have? And then, of course, the very, very concerning research question about whether or not blood transfusions used on a routine basis during pregnancy really lead to improved outcomes or just further expose women to the risk of transfusional iron overload and increased red cell alloimmunization. So on this last slide, I really think that as we move forward in the conversations for today, next slide, we should think about how we are approaching this topic and whether or not guidelines and resources could help us address the what is as we work to shape questions for research for the what needs to be. And I know that the American College of Obstetrics, the Royal College of Obstetrics and Gynecology in the UK has a guideline on pregnancy management, but is there an opportunity to have a guideline for women with sickle cell disease in the US? We have many curative therapy protocols that are coming down the pike for sickle cell disease. Many of them require chemotherapeutic agents that may impair fertility. And is there for a fertility preservation approach a guideline that can be put into place so that we are approaching this in the same way and in a safe way and avoiding some of the risk for thrombosis and increased pain in women who are going through stem cycles? And then also, are there patient-facing information that needs to be developed on the genetics of sickle cell disease and understanding the potential impact of hemoglobin variant traits and those in a woman's risk for having a child with sickle cell disease? And is there a way that we can better prepare young women for this across the lifespan in their reproductive years so that they can have at least a discussion with their physicians on what the best approach may be? As we go through the morning, I'm hoping that Dr. Pecker, as she is about to help us decide how we're going to frame these questions. I hope that the discussions that we have this afternoon lead to solutions that can address many of these disparities and hopefully fuel the fire for future advocacy efforts. And with that, I'm turning the conversation over to Dr. Pecker.
Good afternoon, everyone. I'm just waiting to share my screen with you. Show my screen. There it goes, I hope. And let me make this big. Okay, so I have titled this talk, Putting the Ocean in a Paper Cup, a Framework for Advancing Women's Health Research in Sickle Cell Disease and Trait. My name is Lydia Pecker. I work at Johns Hopkins. I'm the director of the Young Adult Clinic at the Sickle Cell Center for Adults. And my research focuses in fertility in women with sickle cell disease. And it's a real pleasure to be able to meet with you all today under these exceptional circumstances we're all living through. I was thinking of Ernie visiting the moon and looking back at Earth, and our Earth looks so different right now. So I'm extremely grateful to the CDC and to the senior members of the committee who've invited me to share this view of sickle cell disease and women's health in this remarkable moment, and also to remember to think big and to be ambitious about what we hope for advancing this field. So a quick background. So I'm sort of charged with thinking about how to organize this work. So about 5 years ago, Will Savage and the folks who put together the 2014 NIH consensus guidelines published the evidence gaps in the management of sickle cell disease, which was a lovely paper that highlighted sort of two big areas of needed research. They highlighted diagnosis, management, and monitoring, and then also disease-modifying therapy research needs. And so I was thinking about that paper as a frame for thinking about how can we organize the gaps in women's reproductive health knowledge and really women's health knowledge. I've taken that step. It's not just, and I think we all agree, it's not just reproductive health. This alarming slide is one attempt to organize this material. On the top, you see we can think about it across a lifespan. Down the side, you can see we can think about it in terms of reproductive concerns and non-reproductive concerns, and there are a number of sub-issues within each of those topics. And then, of course, within each of those topics, there are any number of truly important and vexing problems. And then, gosh, I can't see it because of where my GoToWebinar control is, but I hope you can. On the far right side is a yellow column that reminds us that sickle cell disease treatments and curative regimens insinuate their way into everything that we now think about with respect to women's health. And so for every one of these problems, there's a parallel question or challenge related to how treatment either could be protective or add an unforeseen or foreseen risk in our patient population. Oops, sorry. So I further simplified that slide to be considerations for 4 categories that I hope we could use to think about how to frame a research agenda in women's health. And those 4 categories are exogenous hormone administration, which I defined here as contraception, treatment for menopause, ovarian stimulation, and cross-sex hormone therapy. Fertility, defined here as fertility assessment, preservation, and preconception concerns. And pregnancy, which I define as everything after the positive beta HCG, which is not to be narrow-minded, but only to attach some organization to our thinking. And then finally, non-reproductive concerns. And although there is some overlap in these topics, I think that this schema works for sort of teasing out some of these issues, and I hope I can prove that to you in the next slides. So within each of these categories, I think that there are about 6, I guess there's 7 if you count 1A and B questions that I think we need to apply. And one of them is research area of concern for people with sickle cell disease, trait, or both. Another is, are there other subgroup considerations, and really defining what is the specific evidence gap that we hope to answer or to fill. And how do disease-modifying treatments or curative preparative regimens inform or shape this problem? How does a patient's location or care environment influence this problem? And, you know, I think that it's important to remember that it's tempting to think only about sort of the US versus Accra in Ghana or Mwanza in Tanzania, but really I think it's within this country there is such variability, right, in the access that adults have to high quality sickle cell care or high quality MFM care and obstetrical care, that location considerations extend not just beyond our borders, but also within the United States. The next question is, what research methods are best suited to answer the problem, to fill the gap? And finally, in the face of all of the uncertainty and lack of answers, are there any optimal clinical counseling, care systems, or guidance that we can make right now? Some within group considerations that I largely neglect for the rest of this talk, but I wanted to say out loud. So first of all, the importance and nature of the answers to some of these questions will vary based on whether we're speaking about women living in high or low resource healthcare settings. And there are special needs for adolescents and young adults that may need to be considered. I think being an advocate for the differences in disease across genotypes is critical and mostly a neglected concern. And so acknowledging that compound heterozygous sickle cell disease is not the same as SS or S beta 0 disease, I think is fundamental to all the work that goes forward. And the extent to which we include, acknowledge, and study the small population we have of transgender men and women with sickle cell disease. And I think probably there's some limits on the kinds of care that we want to recommend. At the same time, there are some real questions for this population. And then finally, not related to these subgroups, but related to us, there are some questions around sort of who does this work? Do pediatric or adult sickle cell care teams with or without reproductive health experts, both OBGYNs and also sometimes in adolescent medicine. So I've made a set of slides that use these 4 categories as a organizing point for a number of different issues that I think fall under them. And so the first of these charts that I wanted to talk you through was questions related to exogenous hormone administration. I believe the main categories that need question, or for which there are questions, include contraception, dysmenorrhea, ovarian stimulation, cross-sex hormone therapy, and menopause. And for each of these, I've listed some, but perhaps not all, surely not all, and the complications or issues that arise with the challenge to our group to really refine what we think the research priorities are within these groups, and to really start to pursue answers to some of these questions. So I think some of the main problems related to contraception for our population are the relative VTE risks of different methods of contraception. We have low uptake of highly reliable forms of contraception. And I think, you know, part of that challenge is a care systems problem of who counsels and prescribes these medications, and how is that care provided. And for dysmenorrhea, I think we miss a lot of dysmenorrhea. So who is screening and when? What are the best treatments? And, you know, are there a role for disease modifying therapies to improve those symptoms? With ovarian stimulation, this is an exclusion to what we'll talk about in fertility, but just to define the risks of uncomplicated ovarian stimulation. So at baseline, what risks are our patients facing? The defined risks, even in non-sickle cell populations of VTE and ovarian hyperstim, may have different implications for our patients, and then are there best strategies to prevent complications? So should we be universally recommending VTE prophylaxis? Should we be universally exchanging patients prior to stim or prior to harvest? What kind of education do the anesthesiologists who sedate patients for egg harvests have? Dexamethasone is a frequently used drug in this population. For cross-sex hormone therapy, we need to define the risks of treatment, define the best and necessary sickle cell treatments as a precondition for cross-sex hormone therapy, guidelines for how to monitor hemoglobin and hormone levels in patients that are at risk for erythrocytosis or thrombosis with estrogen, and to define some best interdisciplinary care practices between the transgender medicine teams and the hematologists. For menopause, I think many women are not clear on the risks of therapy. We need to define treatment standards for this population. And sorry, that's an incomplete sentence, but complications associated with different forms of estrogen. So, I think there's a lack of awareness that the form of estrogen you use seems to modify your thrombotic risk, and really defining whether those differences apply to our population may be warranted. This is what my fertility brainstorm looks like. So again, to walk you down that left column, there's I think the main issues for fertility are reproductive lifespan, reproductive life planning, fertility preservation for prepubescent and post-pubescent women, girls and women. And there's an asterisk there because, we're talking about working with CDC to optimize our databases, and SART, which is the Society for Artificial Reproductive Technology, does not currently collect data that is overwhelmingly helpful if you're interested in sickle cell disease and trait. But I wonder if there are ways to leverage an existing and very organized data collection system to help with answer some of our questions. So for both girls and women, there's questions of optimal strategies and technologies. There's questions of whom we should offer this fertility preservation strategies to. As Andy pointed out, there's real questions about long-term outcomes, right? Who gets pregnant? To what extent does this work? Do people come back and get their eggs? Do they leave them behind for whatever reason? And then I think, there's some outstanding questions here related to hydroxyurea. Do we recommend holds on hydroxyurea before egg harvest? Do we recommend continuing hydroxyurea throughout egg harvest? Do we offer fertility preservation prior to the initiation of hydroxyurea? For example, our French colleagues do this for boys and their sperm. And obviously, I think we don't have data at the moment to support what practice to embrace. And then, of course, the non-myeloablative preparative regimens for transplant have raised a set of questions because they are ambiguous about the degree to which they are affecting female fertility, and it seems to be somewhat variable. And understanding what variables could help predict that could make a difference. And then finally, of course, we know that both for IVF with PGTM that Dr. Smith-Whitley was talking about, and here with fertility preservation, our patients face significant barriers to use. And so identifying which barriers are the most cumbersome and how to surmount them with research probably would be worthwhile. And then finally, the question of best preconception practices. So I think we need to just define what optimal clinical care looks like in this setting, and what our sickle cell management and approach to disease modifying therapy should look like, but also helping to define the risk of sickle cell disease in the fetus and identifying genetic counseling needs, IVF, PGTM awareness and interest in referrals, and again, coming back to that idea of barriers. And then the idea of broad options counseling. So, the number of ways that you can conceive a child and or make a family is ever more dizzying, with sperm and oocyte donations, embryo adoption, domestic adoption, foster care, and many other ways to make a family. So helping families and thinking about how to optimize those care structures and counseling. Pregnancy, so again, I opted not to organize this by trimester. I think there are some other ways we might organize it, but I hope you'll bear with me on this way of organizing it. So again, down the left axis, thinking about problems of the host, health maintenance, treatment, pregnancy complications, the postpartum period, and then the fetus and the infant. And in the host, again, as Dr. James has highlighted, we see alloimmunization and renal disease, pulmonary hypertension, high opioid use, acute chest syndromes, and problems with hips, which I think often get in the way of spontaneous vaginal deliveries for our patients. In health maintenance, there's all kinds of vitamin questions. It's hard to find prenatal vitamins without iron, apparently, in Baltimore. We don't know what the safe and appropriate folate dose is for our patients, and most adults with sickle cell disease don't continue on penicillin prophylaxis, but given the infection risks in this population, is there a benefit to adding that medicine back? We have questions about aspirin for preeclampsia, VTE prophylaxis, buprenorphine for patients with high opioid use, if that would help prevent neonatal abstinence syndrome. the monitoring frequency and where that should take place, the role of anticipating sickle cell and pregnancy-related pain and how to intervene, and then standards related to end organ monitoring, as there are many end organs that require monitoring, and it would be helpful to be able to prioritize some over others, given the obstacles our patients often face in trying to get all of their organs assessed in a short time period. And for treatment, I think, Kim highlighted the need for rigorous data to support an approach to transfusion in pregnant women. And we certainly would benefit from data on when to start and stop disease-modifying therapy. And I think the case for clinical equipoise of hydroxyurea in trimester 3 is intriguing and needs urgent attention. And then we have this novel agent black box with respect to pregnancy and really every other question on this chart. And then for pregnancy complications, all, again, related to some of the things we've already said, VTE, preeclampsia, preterm labor, we have a high C-section rate, and that's supposed to say postpartum pain management. Other postpartum issues is clots, depression, and breastfeeding, and when to restart or initiate disease-modifying therapy. For the fetus and then infant, there are both immediate and long-term consequences of hemolytic disease of the newborn, neonatal abstinence syndrome, being a preemie, having IUGR, and being small for gestational age, and the degree to which we can offer not just guidance for parents and mothers about sort of the immediate delivery period, but what they can expect for their child as that child grows and develops, I think is lacking. A brief list of non-reproductive concerns, and we may decide that some of these are more important than others, or that none of them are priorities for this group at this time. But I think bone health, sex differences in sickle cell disease manifestations, mental health, gynecologic issues, some of the sex-specific cancers, and obesity may be issues related to women's health that deserve attention. And bone disease in particular, I think I'm preaching to the choir. People see this all the time, but I think establishing what the childhood protectors and risks are for long-term bone disease. Our colleagues who are doing research on AVN and fracture risk and sort of geriatric assessments could really help us here. And I think there are a number of outstanding questions about how to improve bone health and whether there's the safety and the role for bisphosphonates in this population. I'm not going to read you the rest of these except to say I do wonder if we miss pelvic pain in women with sickle cell disease, or if we come later to diagnoses of GYN pathologies because we chalk it up to sickle cell disease. And as we face an aging population of women with sickle cell disease, the importance of screening for cancers for which we think there's no increased baseline risk, but nevertheless a population-based risk becomes more important. So I'm ambivalent about this slide, but I wanted to put it up. I don't know that we need this category, treatment and cures, but I think it may or may not be determined helpful to think about each of the subgroups and how the specific treatments that we have available for sickle cell disease speak to each of these topics. I think for exogenous hormone administration, I think it would be so valuable to understand the extent to which various treatments ameliorate some of the hypercoagulability risks in this population. For fertility, this is a very complicated subject. For hydroxyurea, I think the fertility effects need to be defined. The effects on eggs in the short term for people who are going through oocyte harvest need to be defined. Whether there's a dose relationship to this, to any effect we see, if we see an effect. The effects on fertility and timing of initiation for chronic transfusions and iron overload are worth considering. And again, the novel agent black box and the uncertainty related to non-myeloablative conditioning regimens. And in pregnancy and perhaps less so in non-reproductive concerns, there are specific questions raised by each of the agents that we have at our disposal, to treat sickle cell disease. So anyway, this could just be a thinking slide, and we could just use the other 4 slides as a way to sort of see the big picture. But I thought it was worth having a brief meditation on this challenge in particular. especially as we increasingly appreciate the overwhelming benefit of treatment like hydroxyurea for so many of our children and watch them grow into functional adults. So my proposed workflow, I'm not sure if my proposed workflow for this was looks like this. So I think we should agree on groupings, the big table themes, and I've tried to show you what I think that might look like in the previous slides. I propose that we establish research priorities within each subgroup with the considerations that I laid out at the beginning of this talk, including is this relevant for sickle cell disease or trait for any of the other subgroups that we've identified, i.e. high and low resource settings or compound heterozygous disease, that we are specific and naming of the evidence gap we seek to address. We incorporate challenges related to treatment and cure. In some research questions, I expect that will be explicit, and in others it will not. To take geography of care considerations into consideration when we decide on those research priorities, to figure out what the best study designs are, and to think about what, based on what we know now, what are our best recommendations today. If we can do that, I think the next question is to really formulate research questions with attention to those 6 modifiers. And I think for this piece of the work, success would look like a published guide about evidence gaps in women's health and sickle cell disease, and a statement of research priorities. I think with that work, we should also be able to establish a national meeting presence to be continuing to put this on people's radar as a problem. And also beginning to assemble collaborative groups to lead and execute the needed research. And the next thing that needs to happen is the research. So determining methods, leadership, and funding opportunities. And to the extent that our advocacy can help create those funding opportunities, that will be very powerful. I think it's important to define this research as capacity building, which means we need to identify and include as a principle of the work interdisciplinary trainees, junior and mid-career faculty from heme, OBGYN, internal medicine, peds, adolescent medicine, and others who may be interested in these challenges. And then I think the final piece is building some accountability into the system. So what would it mean to be successful this year? What would it mean to be successful next year? With that, I'd say thank you. And there's a lot of inspiration about interdisciplinary teamwork getting the job done thanks to COVID. And here's what happens when pediatricians and internists have to work together. My internal medicine hematology colleagues who I have to work with felt like I was well represented here as the pediatrician on the team. And with that, I can either take questions if that's helpful, or we can, I think Carrie had a break on the schedule. Thanks.
Let's take 5 minutes and be back at round 227, 228, if you can hear me.
Thank you, Craig.
Muted.
Hi, Sheree.
Hey, this is Sherry. I'm here. Can you hear me?
Yes, I can hear you. Everybody's just on a short break right now, and we'll start probably at probably in 3 minutes. Is that okay?
Okay, I'm ready. Yeah, sure. Anytime.
Okay, sounds good.
Okay, Carrie, I think we can start getting wound up again.
Okay, great. That sounds good.
And Mary, if you can hear, you're next. Once your slides are, it should be Mary as opposed to
Can
Sherry.
you,
Sherry, is your connection on and off, or are you good to wait go after Mary?
I dialed in, so it's better. So I can go whenever you want me to go.
Okay, Mary, let's go. Let's start with Mary. I think it will flow well, better that way. So Mary, in about 30 seconds, you can start. Let's give people time to get together.
I'm gonna.
And while we're waiting, I want to thank Andy, Ken, and Lydia. They really gave a great overview and a great perspective on the complexity of this issue. The next two talks by Mary and Sherry is going to talk about data collection, whether it's surveillance or epidemiology, on what is collected, what can be done, and more importantly, on the value of collecting it the right way, using the right codes, so forth. So Mary, I think you can get started now if you're ready. Mary, can you hear?
Yep, I sure can.
Okay, I think you get started if you're ready.
Oh, okay. Sounds good. So I was just going to talk to you today about our sickle cell data collection program, which is a surveillance system we have going on in the states of California and Georgia, and has been going on for quite some time, although in a somewhat limited capacity. So next slide, please. This is the kind of overall goals and objectives of the system. It's to collect, synthesize, and disseminate multi-source population-based longitudinal data. So what that means is we're trying to establish a health profile of the sickle cell population, to track changes and outcomes over time, to make sure that there's credible and scientifically sound information that's available and that information is used to inform policy and healthcare practices. And at the end of the day, the overarching goal is to improve the quality of life, life expectancy, and health among those living with sickle cell. Next slide, please. So this program is different than a lot of the research that's come before in a few different ways. One of the biggest ways is it's a multi-source data system. So rather than using data that comes from a particular clinic or a particular set of clinics or from strictly Medicaid data or just looking at newborn screening data, instead, the SCDC system identifies individuals with sickle cell in each of those different data sources, links it together, and creates this kind of health profile for individuals. So folks who are identified either through newborn screening or who are being seen at a sickle cell disease clinical center are pulled in, and we consider those in most cases to be confirmed cases of sickle cell disease. And then people who we identify through the 4 data sets on the bottom: hospital discharge, Medicaid, emergency department, or vital records, specifically death data, as having sickle cell disease ICD codes, we consider our probable cases. And so those are also pulled into the system. All of that data is linked together to create kind of this index file on each individual who is found in the data. And so right now we have, from all of these different data systems, information going back to 2004 in those 2 states. And then they all, for all of the sources, they have data through 2016. The 2017 and 2018 data is starting to come in, and it comes a bit piecemeal. So it's not complete from all of the data sources through 2018, but it is coming into the system at this point. Next slide, please. And so listening to the presentations earlier today and thinking about, could this potentially be a resource to answer some of your questions that you have about women's health, I think it's important to understand what kind of data is in the SCDC system. So we do have demographic information. For some, we have sickle cell disease subtype. I would say at this point, it's probably 60 to 70% of the population that we know if they're SS, S beta 0, or SC, or S beta plus. But it's not a consistent 60 or 70% across the lifespan. It's definitely skewed toward the younger individuals and knowing their subtype. So for everyone in the data system, we have all of their emergency department and hospital utilization data. So that's information about what date that utilization took place, what the location was, and then we have all of the diagnosis, procedure, and treatment codes that were a part of that particular utilization. For the Medicaid beneficiaries only, we have all of their outpatient utilization information during the time that they were a Medicaid beneficiary. So while we think it's probably around, depending on time and depending on state, somewhere between 60 and 70% of the population with sickle cell disease is a Medicaid beneficiary. I think it's really important to keep in mind that that's not a consistent group of individuals. People come in and out of care, and there's certainly churn in coverage when it comes to Medicaid. But for those individuals who are Medicaid beneficiaries, we also have their pharmacy data. And then we have mortality data on this entire population. Next slide, please. So to give you a sense of the just a basic sense of the kind of information we can pull from this data, we can pull things like geography, so where individuals living with sickle cell disease. We can also pull information about where are they receiving care. And if that is local care, if it is care that it appears that they have to travel a fair distance for, we can certainly tell information about geography. Next slide, please. And then, like I was describing before, we have information about utilization. So Just to give you a sense, this is information about the average number of emergency department visits per year over this 10-year time period for all of the individuals in California with sickle cell disease. And because our data system captures information on the entire population of individuals living with sickle cell, not just those who are going to the emergency department, we really kind of have a true denominator in our data set, and so we have a fairly good sense of what percentage of the population are experiencing different types of utilization, or perhaps experiencing different types of outcomes, et cetera. Next slide, please. The other important thing about this data is that it is longitudinal. We can look at particular individuals and follow them over a long period of time. And this is just kind of trying to highlight on the left. So each of the vertical bars represents about a 1-month period in an individual's life. And this is looking at this individual's emergency department visits over a multi-year time frame. And so, you can look at a 1-year period of life, which is the frame on the left, and see that someone has a really high utilization in that time period. And, you may kind of describe that person as a high utilizer or a high utilizer of services. But we can use our data and actually look out over a very long time period, over multiple years, and see that really that's just kind of what their utilization pattern looks like in a particular period of time, and that when you're looking at a longer period, there's actually a lot of ebb and flow in their utilization. Next slide, please. So probably just as important as what is in the SCDC system is what is not in there. So at this time, and this is not to say that in the future with additional resources and information couldn't be in there, but at this time, there are not any laboratory values. This data does not include patient-reported outcomes. It doesn't really have cost data. I think there are some who might use the data and report costs. I would be very concerned if we were to try and do that. This doesn't have information about education or any kind of like work-related outcomes. It is not connected to electronic health records. So the first slide, or one of the first slides that showed that we receive information from clinical centers, that's a very limited amount of data, a very limited number of variables that we receive from those clinical centers. It's not to say that we're linked up to electronic health records. And then this isn't real-time data. There's obviously a lag in when the data is available and when we receive it. So it's not data that really could be used necessarily for quality improvement in real time. Although you could look back in time and see when a particular policy was implemented or a new therapy came to market or something like that, and see how things changed in the past. It's not something that an institution could make a change right now and see the outcomes of that change in real time. Next slide, please. And so we do have a lot of materials if you're at all interested. Certainly you can always contact me, but there's also a lot of information on our website, a lot of the publications that we've put out, a lot of the kind of companion materials that have been developed, and an overview of the data. There's annual reports from both California and Georgia of kind of what their populations with sickle cell disease look like on a yearly basis. I think that was it. Thanks.
Okay, this is Sherry. Can people hear me?
Yes.
Okay, great. As I said, my name is Sherry Boulay. I'm an epidemiologist by training. I work at the Department of Gynecology and Obstetrics at Emory School of Medicine. Before I transitioned to Emory, I did work at CDC with Craig for a few years. Next slide. Okay, so what I'm first going to talk about is thinking in terms of developing a research agenda, what types of data sources might be available, and kind of some strengths and limitations of certain data sources. So I did like a quick search of the literature, and what I found is that people tend to use a lot of different data sources for sickle cell disease research. My feeling is that studies that draw from a number of different sources would be great because it would contain richer information and it would allow for conducting research across the woman's lifespan. Obviously, the downsides of that is that the linkages are difficult to conduct both logistically and cost-wise in terms of personnel and just acquiring lots of data sets. So that's kind of like a pie in the sky type perspective. But I think probably the best source of clinical information comes from treatment centers, although I don't know to what degree the treatment centers keep information on gynecologic and obstetric interactions. The problem with data from treatment centers is that the number of cases tends to be small and also kind of geographically isolated. And in that case, it seems like research consortia are helpful because they increase numbers and they enhance generalizability. But there can be issues with data access and sharing, as well as standardization of data collection across the different sites. Mary, I think, gave a good overview of what a surveillance system would look like. That's a really rich surveillance system that seems to take a life course perspective. I think the best scenario would be for there to be a national surveillance system, but I recognize that that's probably not going to happen anytime in the near future. Administrative data are a good source of population-based information, and they do allow you to ascertain a large number of cases. So that would include like Medicaid claims data, hospital discharge data, ED visit data. The problem with surveillance data is that they rely on ICD codes for identifying cases, and we know that those have varying levels of accuracy, particularly for specific genotypes. Some administrative data sets also lack information on race ethnicity, which really makes it hard to identify an appropriate comparison group. And then surveys are pretty good for providing like a cross-sectional assessment of health status, especially when they're weighted to be nationally representative. But the thing is, they often rely on self-report of sickle cell disease status. And birth and death certificates are also important, especially if you're looking at obstetric outcomes. Next slide. So there are several things to consider in terms of designing and conducting research generally, but here particularly on sickle cell disease. And I think first and foremost is considering external validity. So we know that studies of sickle cell disease often involve small samples. As I said, they can lack generalizability, and then the cases aren't uniformly distributed, which again affects generalizability of the results. Next is the importance of identifying the cases. So while we know the genetic basis of sickle cell disease, many data sources lack the ability to actually capture the different genotypes, especially, as I mentioned, in administrative data. And there's also seems to be considerable clinical heterogeneity, which may or may not be captured by the data source. And I think both of these are equally important in accurately describing the severity of the disease and the health impact of the disease. Another important issue is the identification of an appropriate comparison or control group. So if you use the general population with all their different ethnic backgrounds, that's probably not going to be the best approach. And it's important to remember that because a lot of case control studies are used for sickle cell disease because it's a rare outcome, is that a critical criteria for case control studies of the cases and the controls must be from comparable populations that are equivalent in all respects, including the opportunity for exposure. There's also the issue of selection bias, so patients with more severe disease may be overrepresented in certain types of clinical research. There's the issue of confounding, particularly confounding due to comorbidities. So there was one study that Craig, I think, referenced earlier today where we looked at sickle cell disease in pregnancy, And we ended up stratifying the comparison group of women without sickle cell disease to those with and without chronic conditions to account for the effects of multi-organ failure. And lastly, I think there are several important statistical challenges that need to be overcome. Low power is a big issue, and problems with this low power leads to low probability of finding true effects, low positive predictive value when you do find an effect, and then often an exaggerated estimate of the magnitude of effects. And then low power also is associated with several other biases. Low-powered studies are more likely to provide a wide range of estimates. So there's issues of reproducibility, second, publication bias, and so that leads to selective reporting of outcomes, and that's more likely to affect low-powered studies. And finally, small studies can be of lower quality in other aspects of their design, particularly if they're kind of opportunistic, and the data collection analysis was conducted with little planning. So that's all I had. And I guess we can move on to the discussion now.
Yes, thanks, Sherry and Mary. Kim, do you want to take over to do the discussion, roundtable discussion?
Hi, can you hear me?
Yes.
Great. So thanks, Craig. I'm very excited about the presentations that we heard this morning, and all of the people that I can see in this chat room. And I'm very interested, and I'm sure Andy and Craig and Lydia are as well, to hear your impressions about what the compelling work is here, your impressions of what research questions that you think really need to be addressed, and what's the direction to get that work done. I know that there have been some questions that have already come up and some hands. So I'm hoping that when people ask their questions that you can state your name, your affiliation, and then in the context of your question, also talk about what you think the compelling work is here and the research that needs to be done and how to get it done. I want to also start by recognizing the Foundation for Women and Girls with Blood Disorders, that I think we really did that in the beginning. And we know that the Foundation has been interested in women's issues and sickle cell disease since its inception in 2010. So I know that that's an interested group, and Craig has obviously been very, very interested in bringing these women's issues forward. As we talk about the compelling work that needs to be done, it would be also great to get some input on other entities and organizations that you think would be important to include in addressing this topic. So with that, Carrie, are we going to start? I think Diane had a question first. So should we start with Diane?
Yes, that sounds great. Let me unmute Diane, if I'm able to do that. Okay.
And if I'm pronouncing names incorrectly, please correct me.
I'm not sure if, Diane, are you able to say something? I'm not sure if your mic is muting.
Diane Nugent, are you on the call? Oh, I just saw the unmute come on.
There she is. Okay, great.
Yeah, it's a series of unmuting. I was just getting good with Zoom, and now we're doing GoToWebinar. So sorry. My question was to Mary, I think it was, who gave the talk on California. We're always trying to see if there's a different pattern for our Hispanic patients with sickle cell in California, in particular socioeconomic and so on. That was my question. It was a while ago. I'll just take a moment while I'm unmuted to say I really believe that the issues surrounding fertility relative to egg preservation and impact on submyeloablative courses is something that is totally worth doing research on, and I would support that. And so I'll mute off because I'm sure that there are a lot of even better questions in the queue. So thanks, and really great conference. Thank you.
Mary, are you still on, and do you have, can we unmute Mary so she can respond to Diane's question?
Yeah.
This is Mary. I'm still on. I'm not sure. I mean, Diane, was your question, do we have information about Hispanic ethnicity in the data? If that was the question, I mean, we do. I'm not sure how reliable it is, and probably there are different segments of the population where I would be more likely to trust that data than others. So we do have it. I think it's probably better for those that we have information either from their newborn screening data or clinical data, and I'm not sure that that then would really cover the entire age group that you necessarily would be looking to study with the particular interest of this group. So not a great answer, sorry.
Okay, maybe we can work on it offline. Appreciate it, thank you.
I know that JJ has his hand up, so JJ Strauss, if you're on.
Thank you. I was thinking back to the questions about hormones, and I wanted to also bring up the issue of iron deficiency, and that's something that I think we've been surprised in a number of women with sickle cell disease is the high prevalence of iron deficiency, particularly in those with more mild, on average genotypes that haven't been transfused.
Excellent. And I see Alicia Nero has her hand up.
Hello.
Hi, we hear you.
Okay, this is, yes, Alicia Nero, UT Southwestern Medical Center in Dallas. One of the things that I think probably was intended, but I'm not sure if we explicitly discussed in the webinar, was the fact, I think we talked a lot about hydroxyurea in multiple levels of the, you know, the planning and family planning of these women. But I also want to make sure that we don't forget the new therapies that are out, because at current time, you know, they're not recommending them in pregnancy or nursing. So as we evolve and as the treatments are evolving and there are new drugs, I think keeping open, of course, we won't have a lot of data and information as we would with hydroxyurea, but I think however this is being built for the future research, that we have a bucket for, you know, sickle cell therapies, period, to include the newer agents.
Yes, Alicia, I agree with you. When you think about getting that work done, can you think about other people that we could bring into the discussion that would either help with funding or resources or data?
I mean, you know, the obvious probably would be the companies who are, you know, getting this. I don't know what's being reported on the FDA level and how to tap into that. So once people are starting to get experience in everything being reported, the other thing is this something that may also be collected by, I guess the insurers won't have any information like that, but maybe on the company level or the FDA level, what they're getting reported across, you know, all providers who are prescribing these drugs.
Excellent. And then I'm just going to go down the list, and forgive me if I miss anyone. I know that Alexis Thompson is on the call, and I was going to ask Alexis to weigh in on what the compelling work would be here, and any research areas that you think need to be addressed, and kind of like what the next steps would be to get the work done. Alexis might be dealing with other issues. Anybody else?
Kim, it may be that, this is Lydia Pecker, it may be that Alexis can speak to this, but I wonder how the ASH-CTN can be leveraged for this research agenda. Do you have any thoughts about that or knowledge?
Yes, I would definitely defer to Dr. Thompson on that, but I think that this is a wonderful opportunity to consider collaborations here, and I know that that effort is starting to get up and running. Mary Houlihan, is Mary still on the call? Mary, I'm wondering, particularly since you've been in the room with a lot of these stakeholders recently, if you have any other thoughts on what initiatives are ongoing that we may be able to link to.
Oh, that's a really great question. And I'm sorry, I'm familiar with the concept, but not the content of the ASH initiative, so I can't answer that either. I think it really depends on what type of information you're looking for. It sounds to me, just as a participant, that there's still a lot that needs to be described, even maybe before actual research takes place. I would offer that while it's only 2 states, there are opportunities with the surveillance data we have if you're kind of looking for big ideas to try and identify. But it's just, again, not a clinician, not on the front lines or anything, but it does still sound to me like there's a lot of opportunity to just even see if you can identify some of these issues that you're talking about in data sets that are available, even if they aren't the most perfect data set, because not to do research, but just to kind of describe what may be going on.
Yeah, Mary, I agree. When I think about what's going on within your network and what the work is that you all are doing with the SCDC, I think it's really important to consider what's going on in that respect as well. Do others think that there is enough information out there that as we think about getting work groups together, it may be feasible to develop some kind of overview paper or review paper, or even contemplate the beginning of guideline development? Or do you think that we need to go right to the research?
This is Andy, and what I'd like to do is offer the Foundation for Women and Girls with Blood Disorders, Sickle Cell Disease Learning Action Network. Alicia Nero is our chair. Hope I'm not stepping on her toes, but offer the Learning Action Network as a platform to continue this conversation, bring people together who can naturally form groups to work on separate issues. And then we have 2 opportunities where we could bring people together in person coming up. In August, there's the NIH Sickle Cell Disease Investigators Meeting. FWGBD has been asked to put on a presentation. It would be nice to have a subset of people who have participated today to help create what that program should look like. The research, for instance, the topic could be the research agenda for women and girls with sickle cell disease. And then use part of the time we have to decide whether we spend all of the time that we have dedicated to present Do we give presentations, or do we organize discussions and seminars within that time? And then the other opportunity we have to get together is at the Foundation for Women and Girls with Blood Disorders meeting in September in Arlington, Virginia, where the FWGBD is not a clinical research organization, but we do have a platform where we can bring people together to work on clinical issues, clinical research, other research agendas.
I think this is
Thank you,
Lydia.
Kim, I think that's great. Lydia, go
sorry.
ahead.
I just wanted to say that I think it is important that we publish something with the identified evidence gaps, and I can speak to the importance of papers like that to my own career. When I was drafting my K and some other early career investigator awards, I did get some pushback from various people about whether studying fertility in women with sickle cell disease was a worthy endeavor. And being able to pick up a paper and show that to someone was really helpful. I think, you know, there's also evidence from the NIH now that underrepresented minorities who are applying for Ks, what they talk about in their K actually determines their funding, and grants with the word ovary were funded at 7%, totally dismal. And so I think that there is an important role for a group of people getting together and publishing what we think are the evidence gaps, because I think it will propel the research, the structure of the research, and the content of the research. In addition to, I love the idea of getting together more and talking more and fleshing these things out, but I think there is some importance to publishing on these gaps.
So I think that that's a great suggestion, and I'm wondering, Andy, if maybe people can at least weigh in the chat room and to see if they have some interest in participating in that kind of initiative. If they could just put their comments in the chat room, then we could maybe even think about getting a small work group together before our August meeting at NIH. But I think that those two face-to-face opportunities are spectacular. There are always challenges when we try to do these things remotely, and I think there'll be great benefit in doing some of this face-to-face. But I wonder if, in addition to an overview or a paper on the gaps, if there's another opportunity for working on this before we meet face-to-face, if there are any other things that we could address that we think are low-hanging fruit before the face-to-face even happens. And I'm just putting that out there to all of the attendings. And if you have suggestions, then please type it in the chat box.
I can't access the chat boxes, so let me see for a second.
But I can hear you, so I would love to hear, Lisa, your thoughts.
Okay, actually, there are a few. I think I had my hand up, or maybe I didn't. I'm technically challenged here. So several. So first of all, if Dr. James gives the okay, I think it's great for the Sickle LAN of the foundation to be involved. I think it's excellent and great. We're actually working to schedule that, LAN meeting remotely. So this is wonderful to kind of put that on that table. So that's one opportunity. The other thing, if we're talking about the low-hanging fruit and identifying where we can pull information relevant to women. So the National Minority Equality Forum has created a sickle index that can be pulled and probed for information. I have not personally played with it. Others have. I have a connection, someone that I've asked to kind of sit and walk me through and can see, because it would be interesting if we can pull out specifically, data and information on females captured within that. So I can kind of, volunteer to look into that and see how specific. Now, again, it's usually pulled from this registry this database is pulling from, I think, mostly Medicaid, Medicare information across the country. But I think anything that we can add to, it may not hurt to see, if the query is simple enough. So that's through the National Minority Quality Forum. That could be a good maybe partner on a global level. The other thing that I'm not sure, those of you who have worked with newborn screening programs, since every state has one, with sickle, and seeing if there's any opportunity to partner, and particularly as a med-peds person and concerned about losing the trait status of a lot of our patients, and would that be a platform to kind of remind people, hey, your child is a carrier, and in the family planning that Dr. Smith-Whitley, talks about, and Dr. Pecker, maybe seeing if we think that that's a good place to, search and gather information. Newborn screening is probably something that we should keep on the list of some of these questions, even though we're talking about reproductive age. I think we definitely can maybe have some information there. So those are just some more things, especially when we're talking about what may be available, accessible in a more broad sense, to tap into these places that already have data.
Excellent suggestions. I'm also wondering, and I don't want to jump ahead to other topics, but Craig, you may know the answer to this. I know that there will be a lot of interest in outcomes in pregnant women with sickle cell disease and COVID-19 infections. And I'm wondering if there are any ongoing data gathering projects where we could try to highlight particularly and capture information on women with sickle cell.
Yeah, the two things. Bob Davis, who's on the line, he's going to talk about, once this roundtable wraps up, he's going to talk about his project in Ghana with sickle cell and COVID-19. And Naomi Tepper from CDC, I think she may have some comments on that, on studies that she may be aware of. And we can come back to this after the roundtable, starting with Bob and then go to Naomi.
Thank you.
Great, thanks. Can you hear me? Is it, so I'll just wait. That's good.
Yeah, we'll just wait.
Perfect, thanks.
And I don't want to jump the gun on that. This is Alicia Nero again. So this will include the COVID-19 registry that's already in existence on that topic when it comes up later.
Bob's, he's got in Ghana, and Naomi can talk in general comments and general terms about what her division, the reproductive health, some things that she's aware of, which may be of interest. I'm not sure if either one knows about the COVID-19 pregnancy registry. If the one that you're referring to, they may. If there is a general registry, you can bring that up. When Bob and Naomi talks about what they're aware of.
Excellent. Well, without any body else's hand raised, I'm not sure if I'm leaving any comments out. So please, if there's anybody that's interested in sharing their thoughts or asking a question, this would be a good time to do so.
Not to put anybody on the spot, but Emily Myers, I think you're on the phone, and Diane Nugent, you could answer this as well. Both of your HTCs are comprehensive with sickle cell lifespan. Have you guys seen any issues in transition between adolescent and young adult that's been missed here, or a signal that happens in children that the adult provider should be aware of?
So this is Diane Nugent. Thanks for asking. We do. I think the issue of hormonal birth control and counseling of fertility does extend into the pediatric stage pretty early on, actually, right around 14, 15. And so it was brought up, the speaker brought that up before. And we have started in our clinic, of course, in OBGYN or girls and bleeding clinic for hemophilia. We've reached out to our colleagues at UCI and the OBGYN group to start a parallel clinic or merging that clinic for women and girls with, just their women's health clinic for them. And we've opened it up to, as young as needed, but in general, the girls are right around 14, 15, 16. And so we're hoping, working with them to bridge this issue, because when they do become pregnant, it is that group that would sort of work with us on the same way. So to answer your question, we are working with our local OBGYN group at the university to set up a transition clinic, not just in general sickle cell, as we've talked about for years, but specifically in the area of women's health. And we feel that really needed to be carved out separately because it raises a whole nother group of issues, and it really doesn't come up as it should in either the pediatric side or frankly that much in the adult side as a particular focused area. And so we're hoping that, number one, we can do a better job at that. I really, Kim's comment resonated with me when you talk to young women coming out of their respective pediatric programs. They come with a lot of misconceptions about their own fertility and risks, and we need to do a better job at being able to answer those. But then also the risk of thrombosis, VTE, for our sickle cell patients that do want to go on to hormonal, any kind of hormonal therapy is huge for us. And we're looking at doing thrombin generation and some other assays to see if we could characterize that risk better for our young women that go on to hormonal, any kind of hormonal replacement during pregnancy. So it's not, I would say, it's in its formative phases right now. We've gotten a lot of positive feedback from the OBGYN folks that have been working with us for women and bleeding, but the transition to sickle cell is moving along. And I would appreciate partnering with anybody else that's looking at these transition clinics, and that would be a working group or a task group that is part of women and girls with blood disorders. I'd be happy to participate in.
Thanks, Diane. Emily Myers from Indiana, do you have anything you want to add?
Craig, this is Lydia. I think she had to step off the call.
Okay. Great.
This is Alicia Nero. I had a question. Is Dr. Strauss still on the call? Is he? Because the question I had for him was, I don't know if he's willing to speak on behalf of SCAPN being a platform to get some information. I think he's used it to send out like links to surveying different practices and questions. So that might be another avenue. And also as a, MedPeds person, he may also be able to speak on, that transition piece as well on that. But that may be another resource and it's quite active now in this COVID setting. I mean, people are really circulating a lot of ideas and thoughts. So it's always a platform to consider if he thinks it's appropriate.
I think for the transition issue, so I'm trained in pediatrics and recently joined the adult group. And what I see in the 20 to 30-year-olds who join our practice at Hopkins is, I think there's some issues around like, what do you know and how do you know it? Do you know it from your community? Do you know it from your hematologist? Do you know it from your pediatrician? There are some ideas around when the ideal time to have a baby is, and I don't know that we engage our patients in that level of inquiry routinely, but young women certainly have ideas about when they're going to have babies, and so I think introducing some standards of care around that set of conversations, as you know, for in our clinic, it's now a routine part of our intake for young women with sickle cell disease as they come into adult care. The other piece is that they're not just transitioning their hematology care, but they're also transitioning often their OBGYN care from maybe an adolescent medicine kind of setting to actual OBGYN. And so, I think the opportunities for wraparound clinics or, hematologists embedded in OB clinics or vice versa is quite appealing. At Hopkins, at least, there's a challenge around how you make that pay for itself.
So hi, this is Kim, and I really appreciate everybody's comments and kind of blending Dr. Pecker and Dr. Nero's comments, as well as Diane's suggestion. I think it would be really nice to try to understand how to collaborate best to organize transition clinics or issues for women with sickle cell disease in a partnership so that we could data gather. I'm also very intrigued by Mary's ability to access data. And one of the things that is intriguing to me is that whenever we have a conversation with individuals about women's issues, particularly about pregnancy, you have to work so hard to make the case that this is still an issue with maternal mortality. So I'm wondering if, and I hate to put you on the spot, Mary, but is there a mechanism through which we would have the opportunity to participate in gathering data specifically on this issue that should really support why we really need to address this in an urgent fashion?
Yes, there's certainly the opportunity, and I would be more than happy to talk more in detail with you, for sure, 100%.
My next thing, this is Alicia Neer again, is more of a question. And Dr. James or the other OB-GYNs may be able to speak to this. I, as a hematologist, I'm not sure what all registries exist that captures maternal fetal outcomes. I do know when they send out reports of, okay, for instance, in Texas, the rate of prenatal care is, and this is coming from somewhere, but I don't know how many exist. What are the good ones? Are there multiple or one best space that is capturing all of this? I mean, this probably is something I should know, but we often get these data because I'm sure if that could be queried for sickle specifically, to Dr. Kim Smith-Whitley's question about data, that might help with the urgency, because where we see that their outcomes may be poor in certain areas or geographic, and then even worse for a sickle mom compared to everybody else. So I don't know if someone can speak to those registries that may be capturing data that some of us hematologists may not be as familiar.
This is Andy. There's not a registry or a way that data are captured prospectively like you speak about. There is in almost every state a maternal mortality committee, but in terms of universal data collection about pregnancy outcomes, there isn't. We look to some states that have a linked birth certificate and maternal delivery information so that the mother and the baby are linked, but there isn't anything nationally or universally. But there's the opportunity to develop it among ourselves.
So Andy, I think you raised a really important issue, and really what the capacity would be to determine what's needed in these data gathering efforts. Mary obviously has access to information on the state level that many of us don't have access to. And some of her data points might be interesting to consider as we think about collecting data prospectively as a group. And I really like the idea of at least having some way of providing real time, not real time, but current data on pregnancy outcomes. I think that that's a nice place to start. I'm going to ask Mary again another question, and Dr. Nero as well. Is there also, can you think of any registries or data gathering? And Andy and Lydia, I think you might have information on this as well. You know, with so many young people going through oocyte harvesting for many different reasons, I know that prescriptions for particular meds involved in that should be capturable. Can you think of any databases that we could query on medications alone to get a sense of how many women possibly with sickle cell disease, where there's cross-referencing capability in certain states, are actually going through some of these reproductive techniques and cycles?
There are prescription databases, and you could look for medications that might indicate sickle cell disease, or look for the diagnosis of co-diagnosis of sickle cell disease. And that would be an interesting study right there in and of itself.
Yeah, like I'm wondering, Andy, if we could cross-reference hydroxyurea in some of these drugs. Some of the stimulation medications.
The only thing
I know
is,
we'll probably get some CML in there as well, but
actually, I think you might get more of the, Lydia, this is Alicia. I think you'll probably get more of the heme malignancies than you would of the sickle. You probably pick up some, right? But
yeah, but more CML and the MDS patients than the sickle cell.
Yeah, possibly.
Yeah,
I mean,
okay.
you know, of course it for sure wouldn't hurt. I guess unless there's a time period, like if you're saying there's overlap between hydroxyurea and these drugs. So I don't know if there's a data, have you ever filled a hydroxyurea? Have you ever filled these, as opposed to, are they overlapping? Because the overlapping would be a heme malignant patient for sure.
This is actually, this would be a good conversation to consider, or fleshing out in the future, if we could bring the group together and really talk about what studies take precedence, what's the low-hanging fruit, how could we make them happen, and maybe take that up on a future call. It sounds like an excellent topic.
Outstanding. Well, I'm not sure that I see any other new questions or hands coming up. So Craig, this might be the time to pass the baton back to you.
Okay, thank you. Kim, I want to bring up one thing which you have alluded to as well as Andy. You know, HHS has or did have a big priority on maternal mortality. And I think if you guys work together for both sickle cell and venous thrombosis, there's going to be a strong case that those two events or diseases, you know, make a pretty big impact on mortality in terms of women. So I think that's something people need to think about, is put this under the umbrella of maternal mortality on a national level and make your case with both VTE and sickle cell, even though they are overlaps, and that might give you some traction, at least in Congress. And with that, Bob, do you want to talk about your COVID-19 project in Ghana, what you and Michael Devon are doing?
Sure. Hi, I'm, excuse me. I'm Bob Davis at the University of Tennessee Health Science Center in Memphis, Tennessee. about for the last year and a half, I and others have been working with a group in Utrecht, Amsterdam, or Utrecht, Holland, in Accra, Ghana, on a study of preeclampsia in Ghana. With the aim, it's a project funded by the Gates Foundation to look at genetic factors associated with preeclampsia, focused on APOL1. And the ultimate goal of the project is to enroll 800 women with preeclampsia and 1,600 controls. At the same time, though, we've gotten to know and actually are working on other projects closely with folks at Corlebu Hospital, which is one of our enrollment sites for the project. And Corlebu is one of the largest sickle cell clinics in the world, apparently. We have interest in working with something called the International Network of Obstetric Survey Systems, which is known as ENOS. I'm not sure how many of you know those, but they've developed a red cap instrument to, they kind of spun it up very quickly last week, but it looks very nicely developed. It queries symptomatology related to COVID-19. And what they would like to do is roll it out in the hospital to assess COVID-19 infection during pregnancy. But given the large proportion of sickle cell in the hospital, certainly at Corlebu, I thought it would be an interesting idea to, in essence, carve out the sickle cell patients because likely they're going to be at higher risk for complications. Now, we are interested. Actually, there's a second hospital in almost the same size in terms of deliveries called Ridge Hospital in Corlebu, in Accra. And then the leader of this project, Kitty Bloemkamp from Utrecht, the University of Utrecht, or Utrecht Medical Center, also has identified apparently 4 large medical centers in South Africa who would also be interested in doing such a project. So we have, now there are also a number of other countries interested in looking at COVID during pregnancy that are involved in this project, but they're all European or Scandinavian, as you might imagine. And so the number of sickle cell patients wouldn't be relevant there. But we seem to actually have a good start at being able to just at least pregnancy amongst sickle cell patients. So I'll stop there, Craig, and happy to answer questions, but go back on mute.
Okay, thank you. Naomi, do you want to say anything from your perspective on what's going on in DRH that you're aware of?
Sure. Can you hear me?
Yes.
Okay, great. This is Naomi Tepper. I'm an OBGYN at CDC in the Division of Reproductive Health, and I also worked on the coronavirus response, CDC's emergency response to COVID-19. And luckily and sort of unexpectedly, we really haven't seen the numbers of pregnant women infected with this virus for unclear reasons. There's just so much that we still don't know about the virus, but unlike what was seen with H1N1 or other illnesses, there doesn't seem to be as much of an effect on pregnant women, or at least not that's being detected yet. We have just a few published case series from China and a couple of case reports coming out. But as far as I'm aware, the only US registry that I know of that's being stood up is out of UCSF, and they are trying to enroll, all pregnant women with COVID, or as many as they can get. As of today, I think they have 122 pregnant women enrolled, and they hope to look at kind of comorbidities and outcomes of the pregnancies in women who are infected. Given the numbers so far, I'm not entirely sure if they would have enough numbers of women with sickle cell disease, although I agree that women with sickle cell disease might be a higher risk sort of subgroup of pregnant women. But I don't know if we will get the numbers. Of course, we're still in the midst of this, and we may get a lot more pregnant women that we just haven't seen yet and be able to get more information. But it will collect, I think, medical information. So it's something that we could certainly communicate with UCSF on the data they're collecting and pull out those sickle cell patients. So I'm happy to answer any questions on that or anything else.
Thanks,
So
Naomi.
this is Alicia Nero again. So there's one that's being sent out, the covidsicklecell.org, where I guess providers of people who have patients with sickle cell that are positive are being asked to enter patients into that registry. I believe it's a RegCast base. I haven't actually logged into the site, but and this one, again, not being on the site, I'm sure probably is collecting as much information, including pregnancy. So maybe getting permissions at some point to pull out the pregnant patients. But I think among the sickle cell world, that's being disseminated widely.
Thanks, Alicia. That was Amanda Payne from our division just sent me that link. And according to the data as of April the 3rd, there were 27 cases reported from 8 states. And of those 27 cases, there were 4 deaths. And as you said, the link is covidsicklecell.org. And there you can find the information.
So Dr. Nero, it's Kim Smith-Whitley. We may, if you're willing to take this on, reach out to, are you referring to the Sickle Cell Secure COVID-19 database?
I don't know which one. Is the Sickle Cell Secure the same Pinto one?
Yes.
Yeah.
Yes.
Along the
Yeah.
website.
Yes.
Yeah. Well, we should maybe talk about reaching out to Julie Panapinto and seeing if she's interested in pulling out that information in the group, and then also talking, just as the speaker just mentioned about other efforts. But I do think it's really worth reaching out to Dr. Panapinto to see if she's interested in really trying to put an increased interest, particularly within that group, in collecting data on pregnant women.
I think we all agree. Is there any questions for Bob or Naomi? Naomi, do you want to mention again about the USCF or the other program?
Yeah, so the UCSF registry is it's called Priority. It stands for Pregnancy Coronavirus Outcomes Registry, and they're basically asking for any, nationally, any pregnant woman who's infected, and the woman enrolls herself. So I think it's self-collected information from the woman. And they have 122 pregnant women enrolled at this point. I'm guessing there will be more as this goes on. And so it's, I think their website is priority.ucsf.edu. And they would collect information on medical conditions, presumably sickle cell disease, but again, I think it's patient self-reported information.
Great. Any questions for Bob on a global scale? Okay, I think we're winding down, and I think it would probably be appropriate if Kim, Lydia, and Andy can leave us with some brief thoughts. And if Michael's on the phone, he can add something as well. So Kim, why don't you start off with your final thoughts?
No, I think that this has been a very exciting discussion on women's issues and sickle cell disease. And it's really brought together numerous people that represent foundations and entities that can play a unique role in gathering data to foster research, as well as quality improvement initiatives, guidelines, and resources that can benefit women living with sickle cell disease. I really like the thought of also getting together and partnering on what we can do for clinics for this group of women with sickle cell as well. And I really also think that having some degree of working groups that continue before we actually have the opportunity to meet in August and then at LAN would be really beneficial. I've learned a lot today. I always learn a lot when the foundation is involved in efforts. And I really also just want to say that we really should have some effort, hopefully Craig with your support, of reaching out to HHS and seeing if there is an interest, particularly in pregnancy and thrombosis, in this group of women with sickle cell. So thank you. I think that this was very successful.
Lydia?
Just thanks for having me, and looking forward to continuing to move this forward in ways that sort of define a research agenda and develop that research. And at the same time, I appreciate what Kim said, Dr. Smith-Whitley, about figuring out the things that we can do now at the same time that we move longitudinal research forward.
Andy?
Thank you, Craig, for making this come to fruition. Thank you, Carrie, for making sure the infrastructure was there for us to participate online. It's refreshing to have the opportunity to move our agenda forward, even then during this difficult time. I will work with Carrie and Alicia to make sure that we have a platform to bring our participants together between now and the NIH meeting. We'll shape up an agenda. We'll consider the clinical issues and the research issues, and we'll keep the momentum moving so that we also have a good sickle cell disease learning action network meeting in Arlington in September. Thanks again to everyone who's participated, to our speakers, Kim, Lydia, Mary, Sherry, and Craig and Carrie for, like I said, bringing this to fruition.
And I would like to add special thanks to Carrie, because she did all the hard work, and her and the foundation deserves all the credit for this. And I would like to thank Lydia, Kim, and Andy for all their efforts they did to make this happen. So thank you all. Have a good evening, and hopefully things will get better for us all in the next several months. Goodbye.
Bye. Thank you.
Bye.
Thanks.
Thank
Bye.
you.
Thank you.